Good afternoon. We're live. It's Thursday, July 16th, 2020, and this is the bi-weekly healthcare provider webinar presented by the New York State Department of Health here in Albany. I'm Dr. Elizabeth Dufour, Medical Director in the Division of Epidemiology at the State Department of Health. Joining us this week to update healthcare workers with our latest guidance on COVID-19, vaccines, and healthcare provider well-being are Dr. Marcus Friedrich, Dr. Betsy Rausch-Fung, and Dr. Louis Snitkoff. Due to the large amount of interest in our weekly COVID guidance updates, we are offering a few different ways to listen to this webinar live and on demand. The audio and slide deck can be seen on YouTube Live. Point your web browser to coronavirus.health.ny.gov/weekly-healthcare-provider-update. The YouTube Live player is on our healthcare provider's webpage. It's mobile friendly, so you can watch it right on your smartphone or tablet. An on-demand version of the webinar is available via YouTube. Go to coronavirus.health.ny.gov, click on the providers link at the top of the page, then click on Weekly Healthcare Provider Update. It is available immediately after the live webinar concludes. For the agenda today, as usual, a number of updates on global, national, and New York State, case count updates, testing updates, the travel advisory in New York State, community mitigation and reopening approaches, treatment updates, vaccine updates for both the COVID vaccine update and ACIP vaccine updates for other vaccines, the travel advisory issues related to healthcare, telehealth reimbursement, and healthcare provider wellness. At the end, there are some resources available to you, and we will have a pre-planned question and answer session at the end with questions submitted to our healthcare provider inbox. And the recordings will be available immediately thereafter, as mentioned, at this link provided in this slide 3. In addition to YouTube, an on-demand version of our weekly sessions for healthcare providers is available in a podcast form. Search NYSDOH. So looking at the global picture, as many are aware, and as has been in the news quite a bit lately, the numbers from the Americas and predominantly the numbers from the U.S. are quite high. So globally, we see over 13 million confirmed cases and over 574,000 deaths. And we see that the bulk of this, more than half of these numbers, are from the Americas at 6.8 million and 290,000 deaths. We see on this global map, which looks similar to the one presented on the webinar 2 weeks ago, we see that the areas in dark, which indicate greater than 100,000 cases in the last 7 days, and the dark brown are still the United States and Brazil, among a couple others. And we see here the WHO epidemic graph. We see here again the increasing numbers, and again, as in prior weeks, and continuing to expand, the portion in the yellow to orange color labeled as the Pan-American Health Organization, the WHO region for the Americas. And we see that consists of the bulk of the cases recently. The CDC continues to have a global level 3 travel health notice due to widespread ongoing transmission globally, and continues to recommend that travelers avoid all non-essential international travel. And here we see from the CDC COVID data tracker the total cases in the U.S. That the CDC has reported at over 3.4 million, over 135,000 total deaths, and over 1,000 cases per 100,000 people. If you look back to this slide earlier, looking at the Americas here at 6.8 million and 290,000 deaths, we see that the U.S. accounts for more than half of the total cases and deaths in the Americas. This map reflects the last 7 days, so we can see the prior map, which is the total, where New York State is in a darker color, given the higher density of total cases. We see here in the map on this slide, this indicates cases in the last 7 days, and here's where we can see the graphic representation of what's been reported in the lay press of many cases in the South and West, whereas more recently Northeast have had lower rates of COVID. And here we see the epidemic curve for the national picture for the U.S., and we see, of course, that increasing trajectory over the recent days. Notably, the U.S. has reported its second highest single-day total for new cases yesterday, Wednesday. And then to briefly review where we are at in New York State, We see here over almost 5 million individuals have been tested since the beginning of the outbreak, with just one day alone on the 14th, over 63,000 individuals tested, 404,000 individuals positive since the beginning of the outbreak, and on the 14th, the most recently available date, 831 were positive. Out of those 63,598 individuals tested, the 831 were positive in New York State. That's about a 1.3% positivity rate. Although that is a slight increase from prior, I believe the more recent positivity rate that was just released is around 1%. And we see that although there might be slight fluctuations over time, we see continued good access to testing, with approximately 50,000 individuals being tested per day, indicated by the blue line on the graph here, and the percent positivity, or the number of positive tests, indicated in the yellow color, and we see that that has continued in the low, around 1% for quite some time now, even after reopening. Here we see the fatalities. Unfortunately, we are now over 25,000 fatalities statewide since the beginning of the outbreak. And for the healthcare utilization numbers, we continue to see low rates of COVID-associated hospitalizations, ICU admissions, and intubations. Currently hospitalized related to COVID, we are at 813 statewide, and a decrease by 18. And newly hospitalized, 71. Current ICU, 165, with no change from the day prior. Current intubations, 88, decreased by 6. And fatalities, again, sadly at 14. However, the day prior was 9, and so we are seeing low numbers, thankfully hovering around 10. Cumulative discharges at 71,867. So now for some very brief updates on COVID testing. A couple weeks ago at the last webinar, we provided an update from the Association of Public Health Laboratories, or APHL, guidance on antigen testing, as we've received a number of questions about this antigen testing. Since that webinar 2 weeks ago, they have provided an update. So this was updated on July 6th, and we see here still they continue to discuss the pros and cons of antigen testing and recommend that it be approached similar to influenza rapid antigen testing, where we can commonly see false negative results due to low sensitivity, as well as false positive results when disease prevalence is low in the community. However, the advantages being it's relatively inexpensive with short turnaround time and can be used at point of care. And this is some further guidance on situations when guidance on antigen testing should be used. Scenarios where it should be considered, such as in outbreak situations or high-risk congregate settings with confirmed cases. And scenarios where antigen testing should not be considered for use, such as screening asymptomatic individuals. Notably, one of the important updates on this guidance is that there is a second antigen point-of-care test available. We see here listed, circled in red, on the second list here of antigen currently available SARS-CoV-2 antigen test. We do also see that, similar to what we discussed last time with a sensitivity in the initial offered antigen test of 80%, we see similarly here a reported sensitivity in the similar range. Another brief update for you is that we have identified that in New York State, there is now COVID home specimen collection testing available. And that's something that your patients and your communities may ask of you as a healthcare provider. If you go to the Find a Test Site Near You on our webpage, and you can search by zip code or city, and we've mentioned before, many test sites come up, both New York State sponsored, Department of Health sponsored test sites, as well as federally qualified health centers and private pharmacies such as CVS and other pharmacies will come up. Additionally, you'll see here at the top the home specimen collection kit that comes up here as an option for patients as they enter this, or for you as you look for a patient. And this is something that LabCorp offers and is now available in New York State. For a brief review of community mitigation and reopening strategies, again, just to provide this review, as we have patients and community members coming to us as healthcare providers asking about travel within New York State or visitors from within New York State, and to know what's going on in bordering communities. So for New York City, we are still at phase 3 of the reopening strategy, although this was modified for New York City to not include indoor dining. So this includes outdoor dining, personal care services, gatherings of 25 people, low-risk youth sports. And the city is on track track for phase 4 reopening on Monday, this upcoming Monday, July 20th. And based on the numbers, whether this will be whether this will occur will be announced tomorrow afternoon. But notably, it's been mentioned that this will be without additional indoor activity. So still maintaining the outdoor focus. The rest of the state, as you see here in the map, is in phase 4, the green color in the map here. And that includes, all of the other counties, with the newest members in phase 4 being Long Island and the Mid-Hudson region. And this includes low-risk outdoor and indoor arts and entertainment, professional sports with no fans, higher education, and malls have been advised in phase 4 that they can open if they have engaged in specific advanced HVAC system improvements. And here are the available resources again for the regional monitoring early warning dashboard and reopening guidance, so that you may look up questions that you or your communities may have in your specific locale. Again, this first one is just to have another screenshot of the percentage positive, so we can see here that we are still on a statewide level, which is the upper part of the slide there, still maintaining that low, as mentioned already, around 1% positivity. But we can then see in the lower portion some of the regional variation, and we can see here that some areas might have slight increases, and these are trends to watch in your locale. Western New York at 1.6% positivity, etc. And again, the early warning monitoring dashboard here is a rate per 100,000 7-day rolling average. Again, statewide, we still see a reassuring, stable, low plateau and resource to keep a close eye on. And here is the hospitalization, and in blue, and ICU in the yellow color, again, still maintaining a quite low numbers, thankfully, and that's something to keep an eye on. Notably, as many are aware, and as was mentioned 2 weeks ago, a new travel advisory in partnership with New Jersey and Connecticut was implemented for individuals traveling from states, either New York State residents who have traveled out and are returning, or out-of-state residents who are coming into New York State from areas with significant ongoing widespread transmission of COVID. And this requires a 14-day quarantine. Here is the website here, which maintains a current list of the states. And so numerous additional states have been added since our last webinar. We're now at 22 states. I won't list them all. They're all on this slide 28 here. And these additions of these states are based on a 7-day rolling average of positive tests in excess of 10%, or number of positive cases exceeding 10 per 100,000 residents. And if an individual has traveled from a designated state, they must quarantine for 14 days from that last travel within that designated state. And the requirements do not apply if it's traveling through that state for less than 24 hours or stopping through in the course of travel. And as mentioned last webinar, there are exceptions for essential workers. What is new and what I wanted to mention today is that beginning a couple days ago on July 14th, enforcement teams have been placed at the Port Authority and regional airports to request proof of completion of the New York State Traveler Health Form. This is stemming from a New York State Department of Health emergency health order mandating out-of-state travelers from designated states to complete the traveler form. And if they're found to have not completed it, there will be enforcement and fines. And so this is a question, again, that many members of your community and patients may have questions about. So we wanted to cover this and also provide the electronic link for the DOH Traveler Health Form, which is available on this slide 29. Other updates from our last webinar: long-term care facility visitation is being allowed to resume on July 20th. And so nursing homes can allow visitors if there have been no new COVID cases at the long-term care facility for at least 28 days. Only 2 people are allowed to visit each resident, and visitors, of course, must be screened for symptoms and temperature, wear a mask, and socially distance while visiting. And long-term care facilities are engaging in all of these plans and processes to implement this at that time if they meet these criteria. Another important update since the last webinar is that the school guidance from the Department of Health has been released. On this slide 31, we have a live link here for the New York State Department of Health pre-K through grade 12 school guidance. It's been announced that schools in Regions 4 can reopen if daily infection rates remain below 5% using a 14-day average after unpause is lifted. However, even if that determination is made, schools will close if the regional infection rate rises was over 9% after August 1st. And the data will be used in the determination made during the week of August 1st to 7th. And prior to that time period, each school district, as many are aware, must submit plans to reopen by July 31st. The guidance is available with this link and really is extensive 23-page guidance that covers masking and PPE, social distancing, cohorting of children to keep them in smaller groups and with as less overlap between groups, restructuring space to maximize in-class instruction and maintain social distance, transportation requirements, food service requirements, aftercare and extracurricular recommendations, screening of individual staff and students, and also contact tracing for any possible cases, and cleaning and disinfection. The New York State Ed Department guidance, SED guidance, will be coming out quite soon. And now for a brief therapeutic update. On the hydroxychloroquine front, there has been some interesting developments since the last webinar. What we find here is that there was a new Henry Ford Health System observational study published in electronic form in a pre-proof form, as you see in the right upper part of the slide here, in the International Journal of Infectious Diseases. In this study, they looked at a cohort of 2,541 patients, and they claim a significant mortality benefit from their observational study. It's notable that there have been many experts in the field and commentaries, including a commentary in that journal on editorial accompanying the publication of that paper, expressing some methodological concerns, including the protocolized use of hydroxychloroquine, which screened out persons with any cardiac risk factors, and that the hydroxychloroquine arm had twice the usage of systemic steroids. Around 75% of those who had received hydroxychloroquine received systemic steroids, whereas about 36% of those who were in the no hydroxychloroquine arms received steroids. As we know, and as was presented 2 weeks ago on the webinar, there have been some early release findings, preliminary findings from the UK recovery trial on the potential benefits of systemic steroid therapy. So this is only one observational study at this point of many that have been published, and the bulk of the other published literature have not seen this kind of mortality benefit. However, I am mentioning it because it is a potential question from patients and community members, given the extensive press and interest that has been raised surrounding this study. Importantly, I also wanted to mention, because subsequently over the last week, the Recovery United Kingdom hydroxychloroquine randomized trial has been published on the preprint server medRxiv, as you see in the second screenshot on the upper right of this slide. That study is a multi-center randomized controlled open-label trial comparing a range of possible treatments with standard of care. 1,561 patients received hydroxychloroquine compared to 3,155 who had received the standard of care or usual care. In patients hospitalized with COVID-19, they found that hydroxychloroquine was not associated with reductions in 28-day mortality, but was associated with an increased length of stay and increased risk of progressing to invasive mechanical ventilation or death. Of course, we are still awaiting a peer-reviewed publication on this topic, as well as publication of other randomized controlled trials on the topic, as we know that the NIH publicized halting their clinical trial, and the WHO also discontinued their clinical trial due to no benefit. A brief comment on the multisystem inflammatory syndrome associated with COVID-19 in children, only to say that we have spoken extensively about this in other webinars, including our last webinar. However, for today, I will mention that the CDC is offering a COCA call for clinicians over the next hour. And if you miss it over the next hour, it's available thereafter. And here's the link available to that. And they have individuals both from Columbia University in New York City, as well as from San Diego, clinicians who will be speaking to this, cardiology, as well as Kawasaki disease, MIS-C experts. And now for a brief update, as many of you may have seen in the lay press, on the COVID vaccine, so to provide a little bit more context. So there are 140 candidates in preclinical evaluation for the COVID vaccine, 23 candidates in clinical evaluation. Of the candidates undergoing clinical trials, 10 are in phase 1 trials, 8 in phase 1-2, and 2 more in phase 1 and 2 separately. 3 vaccine candidates are undergoing or about to enter phase 3 trials. an inactivated virus vaccine by Sinovac, a non-replicating viral vector candidate by University of Oxford and AstraZeneca. This is a weakened non-human primate adenovirus vector carrying the aspect required. This is currently in phase 2 enrollment in the UK, with phase 3 about to start in August. And an RNA candidate, a messenger RNA candidate by Moderna and the NIAID, the National Institute of Allergy and Infectious Diseases, which has completed phase 1, is fully enrolled in phase 2, and about to start phase 3 later this month in July. And we'll speak a little bit more about the phase 1 results that have just been published over the last few days. So the New England Journal has published the preliminary report on the messenger RNA vaccine against SARS-CoV-2 candidate by Moderna and NIAID. And, one remarkable finding here is that it was 6 months from the sequence being published by the Chinese public health officials to phase 1 results being published here, which is a remarkable achievement and far surpasses the years that have been taken in the past. Notably, however, it is important to note that we do not have any current messenger RNA platform vaccines in current use, so this is a novel approach and a novel platform. The phase 1 study published in the New England Journal of Medicine was a dose escalation open label trial with 45 healthy adults aged 18 to 55 who received 2 vaccinations 28 days apart. Future publications will publish further information from this group on those over 55 and some further details and follow-up over time of their antibody responses. Notably, at this time, after the second vaccination, they did find serum neutralizing activity. They found neutralizing antibodies detected by 2 different methods in all the participants evaluated, with values similar to control convalescent serum specimens, so meaning those who had disease and were in convalescent phase after disease. These were similar to those neutralizing antibodies found in those individuals. They did note some adverse events, including in more than half of participants, fatigue, chills, headache, myalgia, and pain at the injection site. And systemic adverse events were more commonly noted after the second vaccination, but particularly with the highest dose out of the 3 dosings offered. So 3 participants in the higher dose group reported 1 or more severe adverse events. So this messenger RNA vaccine, in conclusion, was felt to induce anti-SARS-CoV immune response or neutralizing antibody response in all the participants. And there were no trial-limiting safety concerns identified. And it was felt that these findings support further development of this vaccine through phase 2 and phase 3 trials. However, we still need data moving forward on whether this neutralizing antibody titer predicts clinical efficacy, whether that is a correlate of protection. And notably, there were some findings in non-human primates that supported that potential. However, we ultimately need a large human clinical efficacy study. And as noted already, there is a planned phase 3 trial that is imminent. For your reference, there is a COVID-19 Prevention Network website where a number of public health authorities and academic institutions involved in vaccine trials have come together and produced a website where individuals can go and learn about the different phases of vaccine development and trials and availability of these trials. And individuals can scroll down and click on the bottom if they want to. It says volunteer now. Click if they want to volunteer. And interestingly, this coordinates all of the sites that are offering different vaccine platforms and different vaccine studies to allow for individuals where they're located to be connected to those in their nearest zip code offering any vaccine trials, and also accounting for all of the different types of vaccines and the different study participants needed. And this can be shared with any community members or patients interested. Now we know we've spoken at our last webinar about the importance of catching up on vaccines missed during the COVID outbreak when healthcare visits had decreased. And so we will speak further about ACIP updates with Dr. Elizabeth Rausch-Fung, Director of our Bureau of Immunizations at the New York State Department of Health.
Thank you. Every year, the CDC's Advisory Committee on Immunization Practices issues updated childhood and adult immunization schedules, and typically they release them in February. So in an ordinary year, I would have been giving this update in March, but of course, this was not a typical March. This year, there weren't too many major changes, a lot of footnote clarifications, but I'm going to take them through alphabetically. First, a minor clarification on Haemophilus influenza type B, or Hib vaccine. It's routinely recommended for infants and young children less than 5, and they just clarified for the first time that it's not routinely recommended for healthy children who are 5 or older. Hepatitis A vaccine previously was recommended at ages 2 doses at age 12 to 24 months, with a note that children who had 1 dose should finish up the schedule, and now they've added a clarification that children aged 2 to 18 who never started the schedule should get the complete 2-dose series, and this is especially important because there have been many outbreaks of hepatitis A. So the first major change is with human papillomavirus, or HPV vaccine. First, a review, not changed. HPV vaccine is routinely recommended at age 11 to 12 years, although you can start it as early as age 9 years. They have made a clarification to catch-up vaccination, where previously there were different maximum ages for young women versus young men. They've now made it across the board for all genders. Catch-up vaccination is recommended for all persons aged 13 to 26 years. And depending on their age when they started it, it's a 2-dose series if started at age 9 to 14 years, or 3 doses at age 15 years or older. That's because the vaccine is more effective when given in early adolescence. The FDA recently approved HPV vaccine for an extended age indication through age 45 years. The ACIP, evaluated the benefits and the epidemiology, and they're recommending what's called a shared clinical decision-making for adults on an individualized basis for whether they should receive HPV vaccine. So shared clinical decision-making is a newer term. Previously, the ACIP used to say Category B, or permissive recommendation. Vaccines with a shared clinical decision-making recommendation are not routinely recommended for everyone in a particular group. The recommendation means that the decision should be made on a mutual basis between the healthcare provider and the patient at an individual level each time, not across the board. So consider the patient's risk factors, their values and preferences, your own clinical discretion, as well as characteristics of the vaccine, such as safety, effectiveness, and costs. So a few things to consider. First of all, as I mentioned, HPV is most effective in early adolescence. Most people become infected with HPV in their teens or early 20s. So the risk of becoming infected with HPV for the first time decreases in the late 20s and increasing age. Therefore, the ACIP actually says that most adults aged 27 to 45 don't really need to have a conversation about HPV vaccine. However, at any age, having a new sex partner is a risk factor for acquiring a new HPV infection. So particularly people coming out of long-term mutually monogamous relationships, re-entering the dating pool, age 27 to 45, might be a good candidate for this vaccine. Additionally, the vaccine effectiveness is lower among people who are previously infected with HPV or who have risk factors suggesting they might have already been infected, such as multiple lifetime sex partners. And it's also lower among immunocompromised people. A couple of recommendations to the 2 meningococcal vaccines. So first, ACWY vaccine against invasive meningococcal disease serogroups ACW and Y is routinely recommended for all adolescents with the first dose at 11 to 12 years and a booster at age 16, and has been for several years. There's also a high-risk schedule for persons with high-risk conditions such as complement deficiencies, HIV, or asplenia. For these high-risk populations, there's a multi-dose primary schedule and a series of booster doses throughout their lifetime. they clarified that children and adolescents who have high-risk conditions should keep following that high-risk schedule, even if the ages that they're due don't align to the routine schedule. But on the flip side, healthy children should follow the routine schedule. And so if for whatever reason, travel, something else, for some reason they got their first dose before they were 10, the ACIP recommends repeating that at 11 or 12. So they don't skip over to high risk if they don't actually have some high risk condition. You're not doing every 5 for the healthy kids. Give it 11 to 12, even if they got it before 10, and then a booster at 16. Next, meningococcal serogroup B vaccine, which is another vaccine with a shared clinical decision-making recommendation for healthy teens and young adults. However, it does have a routine recommendation, again, for persons with certain high-risk conditions, similar to the high-risk conditions for men ACWY. Previously, when it was first recommended, it was a 2 or 3 dose primary series, and they didn't recommend boosters. But after examining evidence over time, they're now recommending boosters for these high-risk groups. So after completing the primary series, they should get a first booster dose 1 year after the primary series, and then every 2 to 3 years thereafter, as long as they stay at risk. Additionally, during an outbreak of serogroup B meningococcal disease, public health officials might recommend a booster to average risk people exposed to the outbreak who've previously completed the primary series. Oral polio vaccines are not given in the United States, but they are still given in many other countries. And so it's important to understand how it fits into our schedule when people come to the U.S. from another country having gotten oral polio vaccine. So first, a clarification, which I think is great. In the past, there were different series depending on if you had all oral polio vaccine, all inactivated polio vaccine, which is the shot we use in the U.S., or a mixed series. Now they've said same series, same number of doses, regardless of which vaccine you've gotten. Now, in the U.S., the inactivated polio vaccine we use covers all 3 strains of poliovirus. However, in other countries that use oral polio vaccine, about 4 years ago, they switched from a trivalent strain to a bivalent strain that only covers 2 strains. The ACIP continues to assert that U.S. children need to be immune to all 3 strains. And so only trivalent oral polio vaccine counts towards the U.S. schedule. Because we understand that most records don't actually say the word trivalent or bivalent, they offered a kind of helpful rule of thumb that if the dose was given before April 1, 2016, consider it trivalent and you can count it. But if it was given on or after April 1, 2016, it should not be counted towards the U.S. schedule. Next, there's an update to pneumococcal vaccines for older adults. First, again, a review. All adults age 65 and older should get at least 1 dose of pneumococcal polysaccharide vaccine. That's PPSV23. And I don't love using brand names, but I do with pneumococcal because there's so many initials. So this is the Pneumovax. This recommendation has been in place for decades. It's still in place. Additionally, adults who are 19 and older who have immunocompromised conditions, asplenia, CSF leaks, or cochlear implants are recommended to first get a dose of pneumococcal conjugate vaccine, that's PCV13 or brand name Prevnar, followed by 2 doses of PPSV23 or Pneumovax. Now, previously, the ACIP a couple years ago recommended that adults over 65 get both PCV13 and PPSV23. But now they're recommending shared clinical decision-making for PCV13. But remember, they should still get PPSV23. So they offered a few things to consider when deciding whether an adult should get PCV13 or only PPSV23. First of all, PCV13 is safe and effective for older adults. This change was not based on safety data. However, looking at trends in invasive pneumococcal disease, they found that the risk of PCV13 strains among adults has markedly declined over the last 20 years, tracking along with increases in infant vaccination. However, when they began recommending PCV13 for adults over 65, there wasn't really a marked decline in older adults. So it appears as if the indirect effects of vaccinating infants and young children is protecting older adults more than directly vaccinating them themselves. However, there are some adults who could benefit from it. Adults 65 and older living in nursing homes or other long-term care facilities, or in areas with low childhood PCV13 coverage, or who are traveling to countries that don't have PCV13 vaccine, are at higher risk of acquiring pneumococcal disease with PCV13 serotypes. And adults over 65 with chronic heart, lung, liver disease, diabetes, alcoholism, or who smoke cigarettes are at higher risk of more severe invasive pneumococcal disease. Next slide. And then a few updates on tetanus-containing vaccines. First, another clarification I think is great. In the past, the recommendation was that everyone gets an initial dose of Tdap, and then for those of us who aren't pregnant, the remaining doses were to be TD. But now, again, the initial dose in the series should be Tdap, but the remaining doses can be either Tdap or TD, so you have some discretion there. So for example, everyone gets their initial dose of Tdap, and then every 10 years, either Tdap or TD. Likewise, you can use either one for wound management. And people who are 7 or older who never completed or even started the DTaP primary series should receive, again, initial dose of Tdap. The rest can be either Tdap or TD. But there is now a clarification on children who get those doses of Tdap at age 7, 8, or 9 years. Those doses will count towards their primary series, but not any longer for their adolescent booster dose. So they still need a dose of Tdap when they're 11 or 12 years old. That is a change. However, if they got their dose at 10 or older, that will count towards the booster dose. And so I'll just wrap up with a couple of links. The ACIP schedule is on the CDC website. They also have a great page that summarizes the changes, a really good FAQ on shared clinical decision making. And finally, if you have questions, you can call the New York State Department of Health Bureau of Immunization at 518-473-4437 or email us at immunize@health.ny.gov.
And now for some updates from Dr. Marcus Friedrich from the Office of Quality and Patient Safety.
Thank you, Liz, and thank you, Betsy, for, again, I think vaccinations are so important in our daily practice. I briefly want to talk about two things, just highlight some issues around the travel advisory, but also about the reimbursement for telehealth. For the travel advisory list, you already mentioned that. That came out in June 25th. And I just want to highlight what is important for me in my practice to know and what to tell our patients. So one of the main take-homes that I'm taking from that, if a patient from out of the state or one of these 22 states that are on the list has an appointment, please do not cancel. Make that appointment. Although we want these patients to be in quarantine before and after the appointment, but it's important that this appointment should not be postponed and or an elective procedure if it can't be postponed. And I think that's important to reiterate to our patients who are coming. You also mentioned the traveler health form that is now mandatory for everybody coming in the state with draconian fees that people can face if they're not filling that out. But the main point that I want to make is these exceptions for essential workers, and they should, if they go to these states and stay more than 36 hours or coming back from one of these states, they have to comply with the other DOH guidance on returning to work. So what does that really mean for our practice? Patients from those areas possibly had contact with infected individuals. Just to give an example, Liz mentioned the positivity of COVID test here in New York is around 1%, little over 1%. And I just looked it up. In Texas is 17.5% and Florida 18.7%. And these numbers are still going up. So probably the community spread is much wider than officially reported right now. Make sure that, if you have a patient from that, that they need to be quarantined, not to be in public, separate quarters in their home, and then that there should be a possibility for self-quarantine from other household members. And then there is also in the FAQ, Liz, you also mentioned that I just want to mention here as well, that we put out like 7 days later on July 2nd, there's an extra section on healthcare workers. Healthcare workers also need to be quarantined, but that healthcare entities may allow personnel to work if certain conditions are met. And one of the conditions is if they tested and the test is negative, if they continue to self-monitor 2 times per day and do temperature and symptom check before each shift and use a face mask when working. There is a recommendation to assigning these healthcare workers who came from a state with high infection rate to patients at lower risk for COVID, and then when they're not working to self-quarantine for 14 days. And if they develop symptoms, of course, that they should stop immediately and isolate at home. Another piece that we mentioned in the FAQ are students that travel to these areas during this time. They are required to adhere to essential worker guidance upon return. So similar what I just mentioned, and the same rules apply to them. And then like one of the questions is always, if I have a patient from these areas and I tested him and the test is negative, does that mean that you can come out of quarantine? And the answer is no. Symptoms, as we all know, 14 days is a guidance, but they can occur later than 14 days. And this is important to know and let our patients know. Couple words towards the telehealth reimbursement. We know that the U.S. Department of Health and Human Services, HHS, declared a COVID-19 public health emergency in April, and that included enhanced payments and regulation, including telehealth. And this whole construct of this public health emergency is going to expire in July 25th, on July 25th, and that's next weekend. And I hear a lot of my colleagues out there in the practices that they're very worried, and also the payers that telehealth will go away. There are certain reports from NPR and Modern Healthcare. They already reported that there are plans to expand this public health emergency with everything that is going on, especially the high infection rate in the southern hemisphere of the United States. I cannot imagine like a scenario where CMS would cancel that public health emergency right now. And want to also make sure Medicaid, that the State Department of Health is running, that we have our telehealth, issued by the governor's executive order. And we also expect that the Health and Human Services will expand the public health emergency and therefore the payment for and reimbursement for telehealth. You can look again on the website health.ny.gov/healthcare/Medicaid for any updates. And what does it mean for my practice? The way you used to do and use telehealth now in the practice, continue as usual until we have like clarity next weekend, hopefully during the week next week, that there will be an announcement made from CMS. But I think we all use telehealth to be safe for our patients, for our colleagues, and also for ourselves in a very expanded version. And I don't think that this will go away in the near future. And I would encourage everybody to follow everything around that very closely. And some payers, also national payers, have already signaled that they will continue the telehealth reimbursement in a meaningful fashion. So with that, Liz, I want to give it back to you. Thank you, everybody.
Thank you. And now for some quick tips for clinician well-being in the era of COVID by Dr. Louis Nitkoff.
Thank you, Liz, and good afternoon, everyone. And we're back again this week to talk a bit about clinician well-being and specifically how optimal team-based care can reduce clinician burnout and also improve patient outcomes. Before I start, I'd like to just put in a plug for the webinar that we broadcast last week that was presented by Dr. Carrie Palomara from the Massachusetts General Hospital, Supporting Wellbeing in COVID and Beyond. And there's a link to the on-demand version of that. If you haven't had a chance to see and hear it, I highly recommend it. Today's discussion is drawn from the work of Daisy Smith and others that was published in a National Academy of Medicine Perspectives discussion paper called Implementing Optimal Team-Based Care to Reduce Clinician Burnout. So to begin by defining the healthcare team, there are some important concepts that we need to keep in mind, including the fact that, as we know, healthcare teams are multidisciplinary. They're a multidisciplinary group of healthcare professionals who work closely together to provide high-quality, coordinated, patient-centered care. And in ideal healthcare teams, patients are members of the healthcare team, and that's always the case. But the team participation of various healthcare professionals is fluid over time as patients' needs change. The other important point is that team members do not necessarily need to be co-located, and this is important particularly in the setting of smaller and solo practices outside of hospitals and health systems where team members may be drawn more from the community than from the staff of the institution or the organization. There are also characteristics of successful teamwork, including the fact that there needs to be a clear and compelling purpose. As the saying goes, if you don't know where you're going, you're not likely to get there. And a social structure that enables and facilitates teamwork, as well as a supportive organization that provides an environment that is supportive of the team itself. Appropriate expertise, mentoring, role models, and coaching are helpful, particularly as members of the healthcare team move into perhaps new or somewhat different roles in the course of their need to work more closely together. And there needs to be an environment of psychological safety where there's mutual acceptance and respect, and every member of the healthcare team is acknowledged and welcomed into the team for the knowledge and expertise and the perspective that they bring. There are evidence-based outcomes of effective teamwork in healthcare, and they include improved clinical outcomes in multiple practice settings with multiple medical conditions. And there's growing evidence of a positive association between team-based care and reduction in clinician burnout. The principles of high-performing teams include shared goals that are clearly articulated, understood, and supported. Everybody needs to be rowing in the same direction. There should be clear delineation of roles and expectations with accountability, which is extremely important because teams don't function unless everybody is held accountable to the roles and activities that they are expected to accomplish. Think about group projects, back in school. If there was one member of the group that was kind of a slacker, the entire group didn't function as well as it could. Teams need to be fully staffed, and there needs to be an appropriate patient census. Certainly in times of stress, such as COVID, it may not be possible at all times to avoid a patient census that's higher than ideal, but under more normal working conditions and circumstances, this is an important point to keep in mind. There needs to be mutual trust. Trust is really an essential currency for clinicians. We need to be able to trust each other. We need to be able to trust our patients, and patients need to be able to trust us. Ideally, there should be measurable processes and outcomes that can be used to create PDSA cycles for quality improvement, and there needs to be effective communication between all members of the team. Before I move on, I'd like to take a few moments just to talk about communication and to cite this study that was presented in Medical Care this month, and the link that you see is the link to the abstract. And the study, it's an interesting study. It's called The How Matters, How Primary Care provider communication with team relates to patient's disease management. And this group of investigators studied 27 primary care physicians and 98 team members. So these were clinicians of various backgrounds and training, different licensure, and so forth. They looked at over 26,000 patients at a federally qualified health center that had 12 practice sites. So it was a fairly large cohort. And what they studied was the participation of primary care practitioners in team communications, the time they spent listening, and the uninterrupted speaking length, which is how long they were allowed to speak without being interrupted by another team member. So what they found was that primary care practitioners participated in 75% of team conversations, spent 56% of their time listening, and the average uninterrupted speaking length was only 2.42 seconds, which is just bizarre because, studies have shown that on average we interrupt our patients after about 11 seconds, but it only takes about 2.5 seconds for us as clinicians to interrupt each other. So that's a little disturbing. In any event, all three aspects of communication that they studied correlated with clinical outcomes. So participation, time spent listening, and length of uninterrupted speaking. Clearly, we want primary care practitioners to be more participatory, to be good listeners, and to be given a chance to speak without being interrupted. And ultimately, it's the role of primary care practitioners to mediate these conversations on behalf of patients. And the conclusion of the study was how team members speak with one another may be as important as the content of their communication. So I found that interesting and worthy of passing along. As with anything else, there are potential barriers to effective teamwork, first and foremost of which perhaps is the digital health environment and the electronic health record. As we know, EHRs were not developed to facilitate teamwork and communication among clinicians, and they really don't permit documentation with any degree of ease of the patient's narrative, the patient's story. Documentation in EHRs tends to be template-driven, and it's very mechanical and not very, very personal. In addition, regulatory burdens and documentation guidelines, which were developed over the years to emphasize billing needs versus clinical needs, can be an impediment. And there are workforce issues, which are more personal and interpersonal issues involving the training, mindset, resources, and staffing of clinicians, and the need to step out of traditional, more limited roles that some clinicians have filled in the past and are now stepping in to be more participatory and team members that are part of a more intrinsically functioning team. There are also scope of practice limitations that pertain to certain practitioners, as well as financial considerations that tend to surround reimbursement for services, as the services provided by certain licensed individuals are not necessarily reimbursed at all or well reimbursed, and certain activities like care coordination are difficult at times to achieve reimbursement for. And finally, there is some variability of educational requirements and guidelines for various clinicians. This may be more of an issue when comparing one state to another state, but certainly the need for standardization to foster confidence is also important. As far as solutions, we're certainly all empowered to change our own behavior and to influence the behavior of others on the teams that we participate with. As far as statute and regulatory issues are concerned, this requires advocacy at the state and federal level to help achieve payment reform, revision of documentation guidelines, and change of scope of practice limitations. And we need to prioritize training and assessment of clinicians to encourage best practices and to encourage every clinician to work to the top of their license. Finally, we should reimagine EHR usability and interoperability and EHR workflows so that the EHR becomes a tool that we can use to facilitate the work that we do, as opposed to the current situation where it is a burden that we need to use to facilitate billing and other non-clinical functions. So that takes care of my remarks for today. As in the past, we welcome your suggestions and feedback so we can incorporate those into future programming. I thank you for your attention, and we'll turn it back to Liz. Have a good day.
Thank you, Dr. Snitkoff. The remaining slides I will quickly review through. One to pay note to is the MSNY, the Medical Society of the State of New York, has a new peer-to-peer program for this very issue, clinician and physician well-being. So please look at this. Any physician, resident, or medical student who wishes to relate to a peer supporter may contact MSNY through this email listed or this phone number. And this is a new program they have going. They've already had folks enroll, so we wanted to share that with all of you. The remaining slides are a text function for healthcare provider wellness, the New York State Mental Health Helpline for either healthcare providers or other community members, and other resources, many of which we've discussed before, but they are here for your reference, including telehealth guidance, the healthcare provider compilation of guidance documents, how to find a test site near you link, and some of the printable materials that can also be ordered, or in this case, on this slide, the mirror clings in English, Spanish, or bilingual to encourage hand washing in businesses or healthcare practices. And those can be ordered with the email address listed on the slide, and other printable materials as listed here on how to wear a mask, screening at entry to healthcare, contact tracing, isolation and quarantine. And finally, I will note that it did appear as though this New York health insurance was going to end July 15th. That was just extended. So now New Yorkers without health insurance can apply through New York State of Health through August 15th. And now for question and answers.
Thank you, Liz. Betsy, I have a question for you. Especially, there is a lot of press about the vaccinations. Liz mentioned there are more than 140 vaccinations in production. One of the questions is, please describe the difference between the expedited vaccine production process and the typical process.
Sure. Well, the typical and accelerated processes both contain multiple steps. There's the research and development, preclinical, 3 phases of clinical trials, and then there's also some sometimes lengthy processes of building factories and manufacturing enough vaccine to put it on the market. And so this expedited process still goes through all of those steps. They're not skipping any steps, but they're doing some of them at the same time. So we heard about some vaccines in combination 1-2 phases, some vaccines starting phase 3 while they're wrapping up phase 2. And one of the big time savers is several of the manufacturers already started building their factories even before they started in the clinical trials. So they'll be set and up and running once the vaccine becomes authorized and recommended to use.
Thank you, Betsy. The second question that we are hearing a lot and seeing it on social media, are there any ways to reduce fears from patients and co-workers regarding vaccines and when the vaccine is available? I think that is something that might affect all of us, like this being critical towards vaccinations. Is there anything that can help our physicians to address that?
Well, I think it's important to emphasize, as I did, that they're still going through all the regular processes. They're just doing many of them simultaneously to save time. And the CDC also put out a statement saying that they're not going to lower any of their bars for vaccine safety. So it'll still be held to the same criteria that routine vaccines are held to.
Thank you very much. I think we are at the top of the hour. So again, want to thank Betsy and also Liz again for a very informative webinar. Thank you all out there on the front line seeing patients. Thank you for all you're doing, and stay well. Thank you.
Thank you.